Hello, everybody. This is just wait 5 seconds. Hello, everybody. I'm Shane Tinsley, and I'm the co-founder for the Pursuit of Academic Medicine. And I have the privilege to interview Dr. Herman Gray. Herman Gray is the chair of Wayne State Pediatrics, and he's the former president and chief executive officer of the DMC Children's Hospital of Michigan. Dr. Gray's history with the Children's Hospital of Michigan dates to the late 1970s, when he served as chief pediatric resident. While with the Children's Hospital of Michigan, he also served as vice president of the graduate medical education of the pediatric residency program director, chief of staff, and chief operating officer. Under his leadership, the residency program developed several innovative programs and successfully recruited a significant number of minorities. He is named president and chief executive officer of the Children's Hospital of Michigan in 2005, and he left that position in September 2015 to become the president and chief executive officer of the United Way for Southeastern Michigan. Dr. Gray received his medical degree from the University of Michigan in 1976 and a master's of business administration from the University of Tennessee in Knoxville in 2003, and he is currently a fellow of the American Academy of Pediatrics. He served as the chief medical consultant for the Michigan Department of Community Health, Children's Special Health Services, and as vice president and chief director of clinical affairs for the Blue Care Network. A child and family advocate, Dr. Gray has been honored with numerous times for humanitarian efforts related to pediatric health care, particularly with children with special needs. He has served on a variety of state and national committees and organizations, and he is one of the founding commissioners on the U.S. Medicaid and CHIP Payment Access Commission. Again, thank you for coming here, Dr. Gray.
My pleasure. It's good to see you, Shane.
Thank you. So let's get into these amazing questions that our audience is looking for. So the main point we're going to talk about first is your expertise in academic medicine. So personally, I want to know what was appealing to you and what made you go into academic medicine?
Well, I did not plan this. It sort of came to me, or I was directed to it. My dream was to become a pediatrician and to take care of kids in my hometown of Detroit until I was too old to do it any longer. And then I would sit on a rocking chair, on my front porch and have generations of children, now adults, come and tell me just how wonderful I was. That was the game plan. I fortunately, trained in an very academic residency program. The Children's Hospital of Michigan in Detroit is a moderate to large size children's hospital that, had a very close affiliation with Wayne State University School of Medicine. Mm-hmm. And so all of my teachers, during my pediatric training were also faculty members at the university. And so they were teaching and doing research and the kind of things that academics do. I became intrigued with what they were doing, but still never even at that time, still never thought that I would become one of them. And probably the first thing that really, besides just being surrounded by academics, that really got me pointed in that direction was when somewhere halfway through my second year of residency, mm-hmm. The chairman of the Department of Pediatrics at that time at Children's Hospital, who was also the chairman of pediatrics at Wayne State University, Dr. Sanford Cohen, nominated me along with 6 other individuals to be considered for the chief resident position. Mm-hmm. This is an extra year. Pediatrics is a 3-year training program. Chief resident was a 4th year that you got to sort of be a junior faculty person, give lectures, do a lot of teaching, see all the sickest kids in the hospital. You're sort of a, go-to kind of guy or gal. And, I looked at the other 6 candidates and I knew that all 6 of them were better than me. And I couldn't figure out why Dr. Cohen, would have ever nominated me. And when the decision was announced that I actually had been selected, I was just dumbfounded, delighted, and terrified, all at the same time. And that was sort of my introduction to academic medicine. And had a great year successfully. It was somewhat challenging year in the sense that it was really busy, but I learned tremendously, including how to be a leader, or at least my baby steps towards becoming a leader.
Mm-hmm.
And as a result of that chief resident year, opportunities opened up that perhaps would not have opened up. And so I was offered a position in which I could be a half-time academic pediatrician on staff at the Children's Hospital and part of the Department of Pediatrics, half of the time, and half of the time working in the pediatric practice, which was perfect for me. And I did that for several years. And so that was my introduction. Everything since then, even when I wasn't doing academics, sort of circles back to the foundation of how you think about problems, how you use data, how you use information and research to make patient care decisions, to direct you in many different kinds of ways. All of those foundations came, as a result of, that chief resident year, really, in a lot of ways. And so I owe a debt of gratitude to a physician leader who saw something in me that I didn't see in myself.
That's beautiful. And the amazing skills you gained during that time. Can you just expound upon what skills you gained in terms of like teaching, especially since you said it was a lot of teaching with your new role? Can you talk about that?
Yeah, the resident, of course, is a trainee. They've fully graduated from medical school. They are now in the chosen specialty that they're going to become an attending physician in. And unlike medical school, which is a lot of didactic, book learning, as well as, some exposure, particularly in the third and fourth years, to, clinical environment, residency training is pretty much exclusively clinical training. Although there's a high expectation, obviously, that you're reading a lot and learning a lot, attending a lot of lectures, etc. And so as a chief resident, every morning, I would get to the hospital somewhere around 7 o'clock in the morning. I would look at the list of who the patients were in the hospital, new admissions, what their diagnoses were. Every now and then there would be something that, would be sort of rare or unusual. That's not uncommon in a children's hospital. These are special kind of places, for the sickest kids. I would meet whoever the senior resident was, this third year resident who was on call that night. I would meet them that morning as they're getting ready to go home sooner or later. Back then, it wasn't usually later. And meet with them, discuss what kind of challenges they had during the evening. And then myself, that senior resident, and maybe a couple of second year residents would then start making rounds in the hospital and start in the ICUs or the neonatal ICU. And literally just walk around every patient. Tell me about this patient. Tell me about this patient. Give little tidbits of teaching during that time, because we had sometimes 200, 210 patients to see. So you weren't spending a lot of time on any individual patient, and a lot of them had the same kind of disorder. So you simply nodded your head, say, yeah, good job. Basically, you're trying to make sure that there are no kids who have been missed or neglected, or who got the wrong, therapeutic approach to their problem that morning, so that the resident is then prepared to present the case to the attending physician on whatever unit in the hospital the kid happens to be on, so that they know what they're talking about. So we'll say, hey, did you notice that the sodium was, high on this baby? Well, that looked okay to me. Well, it's okay if the child was 6 years old, but it's not okay if the child is 6 months old. You better have an explanation for that before the attending physician gets here. And by the way, you may be better to do something about it as well. So it was largely clinical, what we would call bedside, teaching on the inpatient setting. So just the kids that are hospitalized that are in the hospital, admitted to the hospital. I would also then be responsible during those days. The chief residents were responsible for selecting the topics for grand rounds every week. So every Friday morning at 8 o'clock, all the faculty, all the residents, all the medical students, everybody who was in the practice of medicine on the pediatric side, not the surgeons or the radiologists or some of the other doctors in the hospital, but all the pediatricians would gather in the auditorium, seats a couple hundred people, and there would be a grand rounds topic presented. And maybe once a month, instead of it being a grants round, it would be a different type of conference, usually CPC, Clinical Pathological Conference. But both of them are teaching, settings, in the topics selected by the chief resident. Sometimes we would know that there was a visiting professor, that was in town and visiting with somebody on the faculty, and we invite them to give a talk. Frequently, it was our own faculty because it was in a large size children's hospital. There are at least 100, faculty members at that time. Now well over that. So you pick those topics. Other teaching opportunities were Dr. Cohen liked to make rounds, once a week or two, with a crowd of residents around him. And so the chief resident had to pick the case, and so my goal in life was to find a case that he could not figure out what it was. Because what happened, we would go to the unit, introduce him to the resident that was going to present the case. The resident, Dr. Cohen, and I would then walk in the patient's room. He would look at the patient and then come out and say, okay, tell me the story. Resident would present the case. And if it was a really good day or a good week, I would have the fun of having the resident say something like, well, this patient is a 7-year-old little boy who developed a fever of unknown origin, 2 weeks ago, and the fever has not let up since. And he's got this, weird kind of little rash on his ankles. And just to make it interesting, the family returned from a trip to Thailand 3-4 weeks ago. And he would say, oh yeah, that's dengue fever. He's like, what the hell? How the heck did he make the diagnosis like that fast? Like, I'd never even heard of dengue fever before. I saw this patient, this guy, doesn't even hear the story, the rest of the history, or do a physical exam or anything. And, there it goes. So, it was my challenge to find something that he didn't know what to talk about, but he was one of the most well-trained, broad-based knowledge, physicians I had ever met in pediatrics, certainly. And I think we'd never, ever actually stumped him. But so you're involved in all kinds of clinical cases. Occasionally, you're on the brunt of it. And so there would be radiology rounds, as an example. And particularly early in the academic year in July, rather than pick on some poor, terrified intern, the chief of radiology who was conducting the conferences, and it is what it sounds like, just putting up x-rays and saying, tell me what you see. So he bring up the chief resident. Now July is also my first month as the chief resident. So what the heck are you doing, terrorizing me instead of one of the first year interns? But that's how it worked. And so you're involved in, academic activity that stimulates you, that keeps you on your toes, that keeps you current. And you learn, how adults, learn, because obviously teaching residents who are, in their 20s, typically, is very different from teaching, high school kids or elementary school kids. They learn differently. There's an art and skill, to teaching. But I came to love that part of, my job. And that's how I ended up, later in life being a residency program director over graduate medical education in one of my roles, because I just really love, teaching. And as you can see, I talk too much. And so
No problem.
it's just one of the most fun things for most physicians, quite frankly, to do in academic medicine, and that's to teach the next generation.
Now, I love how you said that, teaching the next generation about, however, I think you have a unique perspective for a channel that you are actually a chair. So how does your role of teaching and administration tie into what you're doing today?
Yeah, and everybody has their own path, of course. And I wouldn't necessarily suggest to anyone that they follow, my path or anyone else's path, but to listen to what the story is and learn from it, so that when opportunities present themselves, as you're thinking about your career and what, at least right now, makes you excited about the possibility of academic medicine, that you just sort of prepare yourself for what the possibilities may be. I neglected to mention early on that, my dream and aspiration of being that pediatrician on the front porch, that was after I decided to be a pediatrician, because, when I went to medical school, I was hell bent on becoming a surgeon. As it turned out, I rotated through surgery, in 2 or 3 different places. The surgery was interesting enough, but, I really didn't get all that excited about it. It just wasn't meant for me. And as soon as I stepped into, day one of my pediatrics rotation, it's like, man, this is the coolest thing ever. I get to take care of little people who are almost always happy, no matter what a lousy, hand life may have dealt them. And they represent the future, and they, occasionally die, or occasionally, are really disabled, or have serious lifelong kind of problems. Certainly, that is true. But a significant number of them also get well. And the diseases that they have are rarely diseases that are self-inflicted, like, say, alcoholism or drug addiction and all the complications that may come with that. They're just kids, and they're pure, and they, tell you exactly what they think, even if you don't want to hear it. Like, if you get too close and you listen to their heart, and you didn't brush your teeth that day, somebody's going to say, your breath stinks. Or, what's that on your coat? Your coat's not clean. So kids they're just a delight. But sorry to get off of that. But so the interest in administration was initially in, how do we take better care of children? And when I finished my training in that fourth year of chief residency, I joined a practice and started taking care of kids in addition to what I was doing as an academic physician. And that job, just taught me that even with all the things that modern medicine had to offer, there were lots of things that got in the way of care. It could be insurance companies, HMOs, managed care companies. It could be state policies on what things they would approve and what things they wouldn't approve that you think your patient needs. That continues to this day, of course. But over the 10 years that I, was in that private practice / academic medicine sort of combined role, I learned some of the limitations of practice, and that frustrated me. And so I said, well, who are these stupid people that are making these decisions about why, my patient can't get XYZ medication? And so I said, I need to learn more about that. And so I ended up going to work for the state health department and as a consultant for the Medicaid agency for the state of Michigan, the pediatric consultant for the Medicaid department. And, so all of a sudden, I'm now one of those stupid people making the rules, or at least having the conversation with people making the rules and understanding the logic. Public dollars are precious. They need to be spent wisely. If a drug, as an example, is deemed to be not any better than a similar type drug that is half the cost, why would the state want to pay for the more expensive drug, even if a physician wrote a prescription for it, which annoys physicians, of course, but it's a rational use of how state governments make rules. Sometimes there's just limited dollars, and so you're in a situation where I had several cases, working at the state where I had to weigh in and make a decision on a child that had a, uniformly fatal disease. And the family wanted to take that child to the Mayo Clinic or to the Children's Hospital of Philadelphia or Boston, the great children's hospitals in the country, to try experimental therapy. Well, the state would say, we don't pay for experimental therapy. And the only one that can make an exception to that was the person that was in my role as the chief medical consultant for Children's Specialized Health Services. A very lonely position and a challenging position, because literally there would be parents that are calling you on the phone or coming to see you begging for their children's lives. That's what they feel they're doing, because there's no other options except this experimental therapy, which we would approve if there's sound rationale for it, because we're not cold-hearted, and my job isn't to accelerate people's deaths. My job is to save lives, as a physician and to do no harm as much as possible. But every dollar that gets spent on something that is futile, if it is indeed futile, ends up being dollars that cannot be spent on something that clearly can help, a child or someone else. But these kind of difficult, ethical decisions are part of leadership. They're part of physicians' practice. All of us don't practice in areas where necessarily, every day is full of life and death decisions, certainly. Some specialties have more of that than others. But it is part of the maturing process of a physician leader and of a practicing physician, for that matter, often. And so exposure to what I learned in practice, exposure to that job as a chief medical consultant for the state health department and Medicaid I was there about 5 years, was really tremendously helpful in helping to understand all the different ways that physicians can impact people's lives. Direct care, hands-on, doing everything that you can for that person that's sitting right in front of you, or at a big policy level, for a state making decisions about, who gets to receive care. I had nothing to do with how much people got paid for doing what they do, that sort of stuff. It was purely a medical, decision-making kind of role. And that's the only kind of roles physicians typically are in, because you don't want to mix medical decision-making with how much does it cost. Our job is to advocate for what is in the best interest of the patient, and it's somebody else's job to figure out how to pay for it. We should have some responsibility in it. We shouldn't spend frivolously. And as I mentioned, that example of, two treatments being, virtually equal in the research literature, and one is significantly cheaper than the other, then you're always going to go with the cheaper one, so that you can stretch those dollars to care for more people. So, and I guess the last thing I would say about this is that medicine, like many other areas of life, you evolve over time. If you had told me when I was graduating from my training program and going into practice that I would one day be a hospital administrator or a state health department administrator, I think I probably would have gagged. It's like, well, I didn't go to medical school to be an administrator. I didn't go to medical school to be a bureaucrat. I went to school to touch patients and so your interests evolve, your skills evolve, your talents evolve. I was one of the residents that complained to the hospital administration, about what they were spending money on, even though I was clueless as to what most of it meant. I didn't hesitate about complaining about stuff. And so being a leader of the residents in some respects, not, leading them formally, but, just being one of the more outspoken, sort of trainees. And so, you learn as you go along, you evolve as you go along. And so what I'm doing now as a chair is very different from what I did, in those first 10 years, 15 years of my career. Very different.
That's interesting. Can you kind of give us a breakdown about how your week looks as the chair in pediatrics?
Sure. And this is going to certainly vary, excuse me, from chair to chair, from specialty to specialty, certainly, but there's lots of similarities. My role as the chair is to oversee a department of pediatricians and PhD researchers and other staff that generally support the work of the physicians. And so I have sort of two major roles. I'm the president and CEO of Wayne Pediatrics. That's the practice of, that's where we see patients in a building near the DMC campus, near the medical school campus. And those are 15 or 16 doctors there, 3 or 4 nurse practitioners that see patients, every day, Monday through Friday, and occasionally Saturdays. And, the work that I do as a chair of the Department of Pediatrics, I am by Wayne State rules also the president and CEO of that practice.
Mm.
They don't want to have the chair, excuse me, directing the faculty, in one direction, and then another person leading their clinical practice in another direction. It can get very complicated. And we've learned that in a very difficult way at Wayne State in pediatrics, actually. And so I oversee the clinical practice. And so I'm responsible for hiring and firing the physicians. Haven't had to fire any physicians, but hiring the physicians, other staff, responsible for the budget of the practice. The practice, ultimately needs to hopefully be self-sustaining, so the university doesn't have to spend a lot of money on it. This is a new practice, and so right now they are spending a lot of money on it. And we're each month getting a little bit better. And so on one side is the practice, and on the other side is the department. And so the department means the academic mission of the pediatricians. And so that's overseeing the research. So just before I got on this call, as an example, I approved 4 research protocols, by our faculty, need to present their research to the IRB, the Investigational Research Board, that approves, is responsible for the oversight of all research in medical schools. So that takes, maybe for 4 of them, you don't have to read them in depth, but, and depending on who wrote them, you have more or less confidence in them. So if a medical student wrote it, because it's all research, whoever's doing the research, if it's on children, then the pediatric chair approves that. So I, spend some time, usually every day, checking those, seeing if there's any there that require approval. And we may have in any typical week, maybe a half dozen research protocols being written. Our faculty is a pretty active research faculty. I, in the life of the pandemic world, I'm spending a lot of time, as we are now, on Zoom calls or Microsoft Teams or Google Meeting or Ring Central. I can probably name them all, but I'm spending some time. And a lot of time in meetings because my job is more administrative than it is clinical. And so the kind of things that I'm doing after I get off the phone today, as an example, I'm meeting with one of my faculty members to do their annual review. So this young lady is a relatively new member of the faculty. So I'll read her, what she's done in the past year. They self-report it, they write it up, and then I review it, ask questions about it. And then we'll talk about, her career. What does she want to do? When is she planning on going for a promotion? At Wayne State, you come in as an assistant professor, and you progress to associate and progress to professor, ideally. Each one of those steps can take 2 or 3 or 7 or 8 or sometimes 10 or 12 years in between, depending on how productive the faculty person is and what their aspiration and desire is. And so I spend some time, on many days, one-on-one with a faculty member, either because they've got a problem that they want to discuss with me or a career advancement or, development opportunity that they want to bounce off of me, but spend time with individual faculty members. I may teach medical students on a particular day. I may, typically a small group teaching, since I don't see patients any longer. Mine is more kind of small group settings rather than making rounds or bedside, clinic teaching. But most chairs, are not, in that situation. Most chairs are seeing patients themselves. They have their own patient practice that they manage 1 or 2 or 3 days a week, depending on the chair. I ended up getting out of patient care directly because of my many years as the chief operating officer and the chief executive officer of the hospital. It did not allow much time at all to see patients, and I found it dissatisfying to try to squeeze patients in a job that was really very, very full time. And I just didn't feel like I was doing my patients a service. Occasionally, not infrequently, I would have to cancel, seeing somebody at the last minute because something comes up that's an emergency in the hospital that needs to be, that only I can, attend to. And so I got out of patient care around that time. There are some hospital presidents who are physicians who do see patients maybe a half day a week. Typically, they are in specialties where it's a lot easier to do that. So say they may be an ENT doctor or some sort of surgeon. They can do surgery just on that one half day, do 1 or 2 cases, follow up with 1 or 2 patients and not have too much stress about it. I'm a general pediatrician. I like relationships. I like watching kids grow up. I like being there when the kid gets sick. I like answering the telephone. I like doing that kind of stuff. It's almost impossible to do that with another full-time job as an administrator. My day will include discussions, strategic kind of discussions about what the future may look like for the department. So I'm very interested in the care of vulnerable children, urban children who live in urban environments, in particular, Black and brown children. And so we're creating an initiative in pediatrics, to provide more holistic kind of care to the children that come into our clinic. And so besides just providing them with medical care, I've got a social worker and a dietitian right now working on how we're going to address food insecurity. Are we going to hand out groceries? Are we going to have a food pantry in the clinic? Are we going to get donations? Are we going to get grants? Are we going to pay for it ourselves? So I have that kind of conversation. We're talking about the impact of the pandemic on children. And so we're planning, a summertime, because you can be outdoors, yoga sessions for 6 or 8 weeks this summer for, a little bit older kids, maybe 10, 12-year-olds and up, to 18 or so, and teach them yoga, outside so that they can still socially distance, even though that's getting a lot better now, but, in a safe environment. So each day is different. But each day is filled with interesting things to do, and rarely do you even wonder if you're going to be bored, because that rarely happens. The other thing that's not as much fun about a chair, and I've had a similar conversation with the dean of the medical school. He mentioned to me, our dean is in his first year as a dean. He had been a chair in several places, and he's now the dean of the medical school. And we have, routine touch-base meetings so that we talk to each other relatively frequently. And, picked up turned on the laptop, said, "Hey, how you doing?" He said, "Oh, I'm okay." I said, "Hey, well, that wasn't very enthusiastic. What's going on?" He said, "Man, this job, almost everybody that, wants to talk to me has something they're complaining about." I said, "Yeah, that's the job description of a dean." Yeah, sorry. If they had easy things, easy challenges to take care of, it'd be taken care of already. They wouldn't be talking to you. So, there are things about these administrative positions that are just perplexing, or that, don't have easy solutions, or have solutions that, physicians don't want to hear. Well, the solution is that you're going to have to lay off that person because we don't have enough money to pay for them. Well, I don't want to lay her off. I understand you don't want to lay her off, but where's the grant money to support the salary? This is a person that's your research assistant. If you don't have research money, I don't have it either, by the way. What are we going to do? So we either figure it out, or I have to make a difficult decision. Those are never fun, but that's somebody has to make those kind of decisions. And so I guess a summary of this in a way is, similar to my role as a hospital physician or hospital president, is that the higher up you go, in a rank, or administrative responsibilities, certainly not necessarily the associate professor rank sort of thing, but your jobs are always a combination of clinical care and what's in the best interest of patients and providing great care for them, providing a work environment for the clinicians, be they physicians, respiratory therapists, whoever the clinicians are, providing an environment in which they can thrive and be successful and provide that great care, and budgetary and other administrative kind of roles, because it takes all of those things to create an environment in which physicians can practice in a professionally and personally satisfying way. I hear, not so much anymore, but I used to hear a lot of docs talk about, well, we ought to just take over the hospital and we just run it ourselves because, these guys are too interested in money. Well, that every patient that gets admitted to the hospital has to eat. They expect their room to be clean. So there's janitors that need to get paid. These are complex, big businesses. Even, your own physician practice, you're paying rent. You're paying for supplies, you're paying for all kinds of stuff. And I don't want to focus on the money aspects of it because that's not nearly as important to, younger people now. But the fact of the matter is that the better you manage your resources, the better care you can provide. And the more options you have to do more fun things or rewarding things. Fun in the sense that you're doing something really great for somebody else. That's what gets me excited.
That's awesome. And just to wrap up this interview, it's been an amazing experience. What is one thing you wish you learned earlier on that you didn't, that you could have applied in your career in academic medicine back then or now?
That's a great question. And in general, I tend not to be a look backwards kind of person, woulda, coulda, shoulda. But I think if I looked at my career really objectively, there are a number of things that I could have done earlier than when I did them. Unlike many of the people who may ultimately see, this interview, who are thinking about getting an MBA, like in medical school, or not in medical school, but, a combined degree, or who are getting PhDs, combined with MDs, or who are thinking about doing something else very soon after they finish their medical school education or their residency training. I went to business school when I was 55 years old. 53 years old. Anyway, I was old. I could have done it in my 40s probably, but the time was better for me when I was in my early 50s because my kids were older. They were self-sufficient. They weren't living at home. I have a spouse who understood what my interests are. And so I could come home after working all day long and then get online and work on my MBA, for the rest of the evening and do that for an entire year straight. With occasional visits down to the University of Tennessee, where I got my MBA, and spend 7-8 days there 4 times during the course of that year. But I knew I could get through anything in a year. It didn't make any difference how hard it was going to be. It's only a year, and I can get through this. And so it's important to not be intimidated that you don't think you are able to. I think if you had said to me when I was 35 that, you're going to have an MBA degree and an MD degree and you're going to run a hospital, something inside of me may have said, yeah, I guess I could do that. But I think a lot more inside of me would have said, no, that's not me. So dreaming big, thinking big, I'm going to be the best I can be, often falls short of, often you think what you can be falls short of what you actually can be. No matter how talented you are, many people sort of sell themselves short. And I'm not encouraging people to be arrogant or self-absorbed or egomaniacs. But when you're committed to a mission, like patient care or the care of underserved people in our communities in particular, you want to be the best that you can be. They deserve the best that you can be. And, don't let somebody else decide when is the right time for you to start exercising and flexing those muscles. But the first thing you got to do is you got to graduate from medical school. You got to get into a good residency program and become a good doctor. And I chose to do all of that before I started thinking about administration, whether it be academic administration or hospital administration or public health or whatever. I tried all of them.
Mm-hmm.
So it's important to have credibility as a clinician, as a practicing physician, because the people that you will be then supervising, they see you like them. Many practicing doctors, if you're just a suit, you're just the guy that comes around and talks about, hey, get this patient out of the bed. They're taking up too much space, or I can't pay you any money, for what you're doing. You need to get out of here. I'm not paying overtime. I mean, if they see you as that kind of person and just that kind of person and not a clinician, you will have a very difficult time as a physician administrator, be that a chair or any other kind of administrator.
Because it is really a team effort, and you think
That's
to
correct.
have that team mentality.
That's correct. And certainly one thing I learned very clearly is that the physician ethic and the business ethic are really pretty different. So, when you graduate from medical school, you're going to take that Hippocratic oath. And it's still repeated to this day at medical school graduations, or a few of them have a similar kind of oath that's been reworded, but basically says the same thing. You do no harm. Patient comes first. I do everything I can to save that patient that's sitting right there in front of me. That's the physician ethic. The business ethic is provide value to your shareholder, provide value to your stakeholders, to generate profit. That's the business ethic. How you merge those can be a really tricky proposition. Fortunately, most people who invest in hospital systems know, or something that has to do with healthcare, know that they're investing in healthcare, and you can't, take bad care of people so that you can generate more money. That's unethical. And so, you strike a balance, but it's a difficult balance for some physicians to strike, and some, would refuse to even try. Many would refuse to even try. I believe that the more physicians take control of their own lives and their own careers, including working in hospitals, working in medical schools, working in pharmaceutical companies, working in public health agencies, working wherever physicians work, which can be a lot of places. And hopefully, one day, we'll talk about all those different opportunities, or someone will, speak with you about all the different opportunities they are in medicine, because they're countless. You just have to make sure that you are focused on the right things, and the right things are taking care of people, and the money, the institution, the infrastructure. Those are all the tools that you use to take good care of people.
And that's what it's all about. And I just want to say thank you for having this interview with me, Dr. Gray. I know our time is a little bit cut short due to your next meeting, but again, thank you for the knowledge you shared, not only with me, but our audience that's going to watch this video.
It's my pleasure, and best wishes to you, Shane, and to those in the audience. I know you're going to do us proud.
Got it. And the people of the pursuit of academic medicine will continue to do so.
Glad to hear it.